All right, we've reached the half-hour mark, so let's get started. Welcome everyone to this week's installment of the AMSSM's National Fellows Online Lecture Series. My name is Haruki Ishii. I'm one of the sports physiatrists at the NYU New York University. I'll be your moderator for tonight. This lecture series is sponsored by the AMSSM Fellows Online Education Subcommittee, co-sponsored by the Education Committee and the Fellowship Committee. And tonight we will be discussing lumbar spine pathology in athletes. Before we get into our topic for tonight, I want to remind everyone of next week's lecture on sports nutrition, which will be given by Lauren Link and moderated by Dr. James Robinson. The goals of this National Fellow Online Lecture Series is to serve as an adjunct to your individual fellowship program education and to provide sports medicine fellows with direct access to learning from experienced AMSSM members and guest speakers in a variety of formats. Also, this is meant to assist in CAQ exam preparation. Some housekeeping items. So please mute your device, microphone, and turn off your video. You can submit questions at any time through the chat function, and feel free to include your name and program if you wish. At the end of the talk, I, as a moderator, will ask the questions during the Q&A based on the questions submitted. Please also complete the evaluation at the end of the lecture. We love your feedback, so one of our new efforts is to facilitate more input from our audience, and there are a couple ways to do this. First, a web link can be found by going to the AMSSM website. Click the Education tab and then select Fellow Online Lecture Series. The link is near the top of the page as seen in this screenshot. Second is by scanning this QR code. It should take you directly to the form to fill out. When filling out the form, we ask that you please keep in mind that the primary goal of this series is to assist in CAQ preparation for fellows. And now I'd like to introduce you to our expert speaker tonight, Dr. Aditya Raghunandan. So Dr. Aditya Raghunandan is an assistant professor in the Department of Rehab Medicine at UT Health San Antonio. He's a board certified in PM&R, sports medicine, and electrodiagnostic medicine, and also a registered musculoskeletal sonographer. He specializes in the care of acute and chronic musculoskeletal sports, as well as spine conditions. He graduated from Rutgers Robert Wood Johnson Medical School prior to serving as Navy flight surgeon for 8 years. He then completed PM&R residency at Ishun School of Medicine at Mount Sinai, and subsequently a spine and sports medicine fellowship at the Hospital for Special Surgery. He currently serves as the Associate Program Director for the PM&R program, the Form and Function Module Co-Director for MS2s, and Clinical Skills Core Faculty for MS1s at the Long School of Medicine. He is also involved on committees on AMSSM, International Pain and Spine Intervention, Associate of Academic Physiatrists, AAP, and AAP-M&R. Now, without further ado, please welcome Dr. Raghunandan. Let me stop share.
Hi, everyone. Thanks for the intro. Give me a second while I share my screen here. All right. Well, yeah, thanks again for having me. So the goal for today is a couple different things. So one is primarily for preparing for your CAQs, and then I'm also going to give you some clinical pearls. So as you move forward in your career, and if you have some clinical conundrums or questions, hopefully this will help with some of those as well. So here's the objectives. So I'm going to go through normal and abnormal spine anatomy and relationships, identify some potential causes for spine pathology. I'm going to focus here on younger athletes, but I'll talk briefly about spine pathologies in general. Some rehab pearls to kind of take towards the CAQ, but also moving forward in your clinical setting, and then some interventional spine pearls. So big picture, and I don't think this is a surprise to anyone on this talk or anyone listening to this talk, but the scope of the problem is when it comes to low back pain is pretty significant. It's pretty large population burden, not only in the US, but also worldwide. And it's the single leading cause of disability worldwide. In a person's lifetime, they usually have, most people experience at least one episode of low back pain. Most of this occurs in the 50 to 55-year-old age group, and then after the age of 80, that number starts to diminish quite a bit. I want to talk a little bit about some names that are kind of out there, some taglines, things like non-specific back pain. So going back to the origin of this word, or kind of the origin of this term, it dates back to a study that was done in the 1940s, where it was an orthopedic surgeon who wanted to essentially do an epidemiology study, and he had 3,000 continuous patients with lower back pain. And if you look at the diagnoses, it's pretty varied and pretty vast. So it ranged from intervertebral disc disease to rheumatologic disorders, to fractures, to infections, all the way to cancer. So pretty heterogeneous group. And this is kind of the initial study where the term non-specific back pain came from. And since then, we've evolved quite a bit as far as modern imaging diagnostic procedures. So the current prevalence of uh, back pain being non-specific is actually pretty low. So there's a couple studies. I'm going to quote one specific one, but there are definitely studies since then that have showed that the term non-specific is actually not as helpful. And most pathologies that are chronic back pain actually do have a diagnosis for them. So getting into anatomy, so what I teach my fellows or my residents is to come up with a systematic way to break down any musculoskeletal part. So there's different ways to do this. As long as you're systematic and you have a methodology, you won't miss pathology. So a method is to start kind of with deeper structures and then move superficial. You could do the opposite. You can also do systems-based, but this is a method that you can use. So if you start at the deepest structures, you could think about the bony elements. So think about the spine or the spinal column as a three-joint complex. So you have the vertebral bodies with the intervertebral disc that's in between, and then posteriorly you have the facet joints. These other elements are part of the bony elements that allow either neural structures to exit or attachment sites for ligaments. The soft tissue structures are the intervertebral disc and the ligaments. That's kind of the broad picture. We're going to do some deep dives into this anatomy in a next couple slides. But the intervertebral disc, primarily two parts, the annulus fibrosus and the nucleus pulposus. The ligamentous structures, really their job is to hold the bony structures together, but they can be involved in pathology if they're disrupted or if they're hypertrophied. As far as the muscular elements, so this is things that are muscles that cross the joint. So the spine and the hip have a pretty intimate relationship, but the spine specifically, there's three extensors going from superficial to deep. So you have superficial, intermediate, and deep layers. And then flexors, you have the intrinsic muscles that are your, quote unquote, core muscles. That's your transverse abdominis is the largest of those. And then you have the extrinsic muscles, primarily the iliopsoas. Lateral flexors, the only true lateral flexor is the quadratus lumborum that produces pure lateral motion. There are other co-contractions of flexion and extension muscles that also allow for lateral flexion. There are rotator muscles as well. They attach to the transverse processes as well as the lamina. When it comes to the neural structures, really the big one that we think about or consider is the spinal cord. So if you remember, in most adults, it ends around the L1, L2 region. Some people a little bit higher than that. So when we're talking about cord pathology, usually when we're in the lumbar spine, we don't have cord pathology. That's more of a thoracic and a cervical spine issue. Spinal nerves exit through the neural foramina. Medial branches, they come after the spinal nerve has exited, and then the medial branches innervate the joints or the facet joints primarily. There's also innervation to the multifidus muscle, which are extensor muscles of the spine. And then the discs also have nerves, disc in the vertebral body. They tend to be on the outer portion of the both the body and the discs. And those are the sinovertebral and the gray rami communicans. Neural anatomy, I think it's worth doing just a quick deep dive into this, just because there's terminology like nerve roots that get thrown around without complete understanding or kind of a deep dive into what a nerve root actually is. So those of you who are interested in cadaver dissections, Roshing has done, or Roshning, I'm probably mispronouncing that name, but he's done some amazing cadaver work where he does a really good job detailing anatomy, not only in the spine, but other musculoskeletal regions. And it's, for those of you who are going into this for a career, I think it's worth taking a look at some of these, because these structures are pretty cool to look at in a cadaver. But hopefully you could see my mouse here. So when we talk about nerve roots, we're talking specifically about the motor and the sensory component. And as you could see here, the motor and sensory component travel together in the spinal canal. After they exit the foramen, or once they're in the foraminal zone to outside the foraminal zone, they're no longer called nerve roots at that point. So if we zoom in on this area, so there's a cartoon schematic on the left and a cadaver dissection zoomed in here on the right side. So you could see that there's a motor component, and then you also have a sensory component. This sensory component gives rise to the cell bodies, which are dorsal primarily. And then after that point, you can look at this cartoon schematic where they combine together to form the spinal nerve. So once you're at the foraminal level and beyond, they're no longer spinal nerve roots. So nerve roots don't exit the spine, they stay in the canal. And then once the spinal nerve exits, then it splits off into different type of branches. So the dorsal ramus, the ventral ramus, and then you have other branches like the medial branch. The intervertebral disc are primarily two components, like I said earlier. So the nucleus pulposus is primarily water or type 2 collagen. And then the annulus fibrosus, this is a pretty neat structure also when you look at it under a cadaver dissection, but it's essentially these lamellae, which are obliquely arranged in 30-degree cross sections that encase the nucleus almost like a bird's weave-like basket. And they attach on the superior and inferior aspect of the end plates. And these this orientation specifically is very good at withstanding distracting forces and bending forces, but they're not really good at torsional stressors or forces. So this kind of comes into play when we talk about disc herniations. So getting into differential diagnoses, so I split this into differential diagnoses for axial pain or axial back pain, and then differential diagnoses for radicular pain. So it's different. This is just kind of a list, and you can see it's pretty vast. And to be honest, we don't have time to go through all of these today. So I'm just going to highlight the ones that I think are probably most board relevant, and then probably most relevant as you move forward in practice as well. And then same thing with differential diagnosis for radicular pain. That also is pretty vast. So some things to think about. So when a patient says sciatica, do they mean radiculopathy, or is this coming from a spinal nerve, or is there another structure causing symptoms down the leg? And from a lot of imaging studies now, we know that the sciatic nerve is actually not what's involved. In most of these, it's usually a spinal nerve component that's involved. Other kind of go-to diagnoses are things like piriformis syndrome. This in reality is actually pretty rare. And I'll have a slide on this kind of later down the road as well. So hopefully after this lecture, the word or the term piriformis syndrome isn't high on your differential, and hopefully it drops a little bit lower on your differential. All right, so differential diagnoses for athletic spine disorders, again, are pretty vast. The way I'm going to break it down is kind of based primarily on, is this axial or radicular? Other things to think about are age of the athlete. So when we think about athletes, I think kind of the go-to is to think about your adolescent athletes or your early adult athletes. But remember that, this kind of spans the spectrum, and it'll span the spectrum as to what you see in practice as well. But the focus of this talk, for the sake of time, I'm going to focus primarily on the adolescent or the young athlete. So here's some of the things I'm going to talk about are kind of the axial versus radicular, and then specifically I'm going to focus on these three areas. So discogenic or disc-mediated pain, facet-mediated pain, and then spondylolysis, which is a special entity, but I think it requires a little bit of a deep dive, especially when we talk about athletes. So one big takeaway from this lecture, if you don't remember anything else, is really think about directional preference. When you see a patient, the first question you should be thinking about or asking them is their pain worse with flexion, or is their pain worse with extension? That really helps you hone or kind of narrow down your differential diagnoses. And it can start asking you, have you ask questions down a specific pathway, start thinking about differential diagnoses in different pathways. And then a lot of patients, especially as they get older, if they have some fear avoidance type stuff, which we'll talk about in a little bit, they may have pain with both directions. And then there are some ways to manage that as well. So red flags, I think most of you probably know this at this point, but I think it's worth mentioning. Red flags are things that should make you take a pause. And these are things that might need to go to elevated care sooner than later. So think about the age of the patient, or if someone is younger than the age of 18 or older than the age of 45 and have a new onset of axial pain or radicular pain, that should make you take pause. History of cancers, significant trauma, constitutional symptoms, pain that's unrelenting regardless of the position that they're in. If it's disproportionate to a typical musculoskeletal pain, think outside the box. So go back to that differential slide and think outside the box of MSK. If there's unexplained weight loss, if there's bowel and bladder changes. So the term bowel and bladder, and then I specifically want to say the word changes as opposed to incontinence. So it depends on which part of the spine is involved. So if the spine is involved above the thoracic level, so thoracic and cervical, those patients tend not to have incontinence. They tend to have more of a retention issue. Those below the conus tend to have more of the incontinence, so things are more flaccid. And then if you have a conus involvement, so where you have the tapering part of the spinal cord with the spinal nerve involvement, you kind of get a mixed bag of both upper motor neuron and lower motor neuron. So just things to think about when you're asking questions there. Systemic illnesses, if there's in an immunocompromised or immunosuppressed state, and if there's any other chronic issues that would put them in an immunocompromised state, those are potential red flags or should give you a reason to pause. The other thing I want to mention is yellow flags. So yellow flags, these are things that would put a patient into a more of a chronic or increase the risk of chronicity when it comes to back pain. So there's a couple studies looking at this from the industrial rehab world or occupational medicine world, where they look at coping mechanisms of different patients. So personality factors really play into a lot of this stuff. So think about how does your patient or your athlete cope with stress? What is their self-efficacy beliefs? How do they handle distress? There's some very easy, quick, short forms that are out there, which many of you may have used already to give you some of these data points as well. So some things to consider if you're seeing a patient is fear avoidance behavior. So these are either things that they tell you during your interview or your history taking or during your exam. So these are things like you have an expectation that doing a certain movement is going to cause pain, even if you're not actively doing it, or if you're trying to range this patient or do a range of motion of their lumbar spine, or if you're trying to do straight leg raise, they start to anticipate the pain even before they have it. That should start raising some yellow flags for you. So these are patients that you might want to take a more of a biopsychosocial type approach to this patient. Another term that you may have heard of or physical exam maneuvers, you may have heard of the Waddell signs. So this was initially proposed by a Scottish orthopedic surgeon back in the 1980s. And it's used as a screening tool for non-organic signs of lower back pain. So it's been kind of become a little bit more legal oriented as far as calling out a patient for lying. That's not really what it's meant for. It's really meant to see, is there a psychological or a biopsychosocial aspect to this person's pain, like fear, anxiety, catastrophic thinking, perceived disability, depression, and things like that. So you can use Waddell sign, just understand what the reason is for doing it. And if these yellow flags are going up for you when you're seeing your patients, think about more of a shift in more of a cognitive approach and less of just a musculoskeletal approach. So a multidisciplinary approach can help for this. As far as the exam, I'm sure you're getting a lot of this during your fellowship. You're a plug for the AMSSM workshop. There's going to be a med student resident and fellow workshop at the conference coming up where we're going to go through this in some detail. So I'm not going to go through a full lumbar spine physical exam here, but I just want to highlight some of the the wave tops here. So the things that you learned in medical school still hold when it comes to doing an exam. So the basics are still the same. So inspection, range of motion, palpation, and neuromuscular components of the exam, that still will get you 80% of your diagnoses. Special tests and special maneuvers, we learn a lot of this during fellowship for specific maneuvers, for specific pathologies. These are really icing on the cake when we're thinking about pathology. So you should be 80 to 90% of the way there with your diagnosis, and your special maneuvers should be used primarily as a confirmation or confirmatory test, because I'm sure, as most of you know, the sensitivity and specificity for some of these tests are all over the place. So putting it into clinical context is really what we're trying to do. Kirkcaldy-Willis cascades, those of you who are physiatrists or are about to take the physiatry boards, hopefully know this diagram pretty well, but this Kirkcaldy and Willis, these were also, I believe, orthopedic surgeons in Europe who came up with this cascade of thinking of the spine as a three-joint complex of the intervertebral disc, and then the facet joints, two facet joints posteriorly. And over time, or kind of the natural history as to what happens with the spine and with earth gravity and then just living life. So they split it into two components: what happens to the facet joints and what happens in the intervertebral disc. And they split it into three phases. So a dysfunctional phase, unstable phase, and a stabilization phase. And then they kind of split it into what happens to each of these components during those phases. So I think this is a nice chart to kind of understand. I'll leave this, you guys will have access to this, but I think it's helpful to look through when you're thinking about pathologies, about what's normal, what's abnormal, and then which part of the pathologies or which part of the anatomy is playing into pathology. Spondylosis is another term that I like to ask my med students and residents when they rotate, what is spondylosis? And really it's natural history of the spine. So if you think about what happens to the spine with time, you start to get increase in disc forces because of gravity. That causes loss of disc hydration or dehydration, or desiccation is another term you might see. That causes loss of height. That puts more load posteriorly on the posterior elements, which is essentially the facet joints, the pedicles, the lamina. That increased load causes facet dysfunction or facet arthropathy or hypertrophy, which can lead to canal stenosis, central canal stenosis, and foraminal stenosis. So it's kind of a big picture terminology that refers to the natural history of the spine. And here's kind of the analogy that I use and what I talk to with my patients. It's like getting gray hair and wrinkles in your spine. So these are things that you're going to see on imaging. These are things that is going to happen to you in life. It doesn't mean that just because you have a finding on imaging that is pathology or a cause for pain. So just understand that there's natural history to the spine. Another thing I think it's good to have a baseline of is understanding disc terminology. So the Farden classification is a really good article where spine surgeons, interventional spine physicians, both anesthesia, physiatry, and other disciplines, as well as radiologists got together and they came up with a consensus of terminology to use. Because the terminology is pretty vast out there, depending on what radiology reports you're reading or where you're training. So this kind of puts things into a standardized format. So the convention is splitting a disc into 4 quadrants. So you can think of this either as 90 degrees or 25%. And some definitions here. So one is, if you look at a sorry, we'll start with the herniation down here. So focal herniations are anything that's less than 25%, that's a herniation. And then broad-based, these are bulges. So broad-based disc bulge is anything that's 25 to 50%. And a symmetric disc bulge, which is what this is 50 to 100%. So one thing another kind of take-home point, a bulge is not a pathologic process. This is natural history of the spine. So this is something that patients can kind of get fixated on if they see that in a report, and some physicians also get fixated on, but a bulge is not necessarily a pathologic issue. If there's neural tissue that's involved in a bulge, then yes, it can be pathologic, but a bulge in and of itself is not a pathologic issue. And then as far as disc herniations themselves, splitting them into 2 different categories is helpful. And understanding these differences are helpful both kind of at a histological level, but also at a clinical level and prognosis level as far as when you're talking to your patients. So the two big types of herniations are protrusion and extrusion. So the definition of a protrusion is the base is larger than the amount of disc material traveled. And extrusion, on the other hand, the base is smaller than the amount of distance traveled. So when you're looking at these on MRI, the extrusions look more dramatic, but they actually respond better clinically or do better clinically as opposed to a protrusion. And the reason is this. So if you look at a histologic level, extrusions tend to be infiltrated with inflammatory cells and neovascularization. So it's a highly inflammatory state when you're in extrusion. These tend to get eaten up by macrophages relatively quickly. A protrusion, on the other hand, so I'm from the Northeast and I train on the Northeast. It's kind of like if you have a tire sitting out in the winter and you don't put it into your garage, over time, the rubber is going to dehydrate and it's going to creep, and a bigger portion of the tire, a bigger portion of the disc is involved. And it's more of a fibrocartilaginous matrix change of dehydration. So a bigger part of that disc is involved, but it doesn't protrude as far. So these take a long period of time. Sometimes they linger forever. So these are prognostic indicators that you can tell your patients. So if you see a big, large disc extrusion, and kind of the continuum of this is something called a sequestration, where a piece of disc can actually come off. Those actually, they look very dramatic. They respond really well to therapy. They respond really well to injections. And if surgery is required, they respond really well to surgery. So the prognosis for an extrusion is really good. Protrusion, on the other hand, because a larger portion of that disc is involved, and it's a little bit more of a chronic process, which has now changed to a fibrocartilage matrix, these tend to linger, and patients who have issues with this tend to have symptoms for longer periods of time. And then as far as the disc pathology, so not all disc herniations are created equal. So things to consider when you think about discs. So you can have axial pain or pain specific in the back without going down the leg. That is usually due to an annular tear. So it's an acute moment where you have a flexion with a rotation component that usually causes that. The word tear we'll get into in a little bit as well, but fissure is probably a better term, but tear tends to denote something that's a little bit more acute in nature. You can also have discs that herniated to different zones. So you can have pain with flexion. You can also have pain with extension with the disc herniation, depending on where that disc is herniating. In the lumbar spine, this might show up on your CAQs, but the most common axial location for disc herniation is in the subarticular zone. So subarticular zone refers to it's just off midline, so it's not right in the center, and it's just anterior to the facet joint. So the articulating process is the facet joint. Subarticular zone is where that happens. And if you look at kind of the disc anatomy on cadavers, that's usually where you have the weakest structure, weakest part of the disc, which is why disc herniations tend to happen most commonly in the subarticular zone. These tend to be better with standing, but worse with flexion. It also is worse with increasing disc pressure. So things like sitting, so coughing, sneezing, going to the bathroom, defecating, those kind of things can aggravate these symptoms. You can also get pain with extension if it's more in the foraminal zone or extraforaminal zone. That is actually worse with extension and better with flexion because you're actually decreasing the force on the disc. So this is kind of a depiction of some of that through cross-section, talking about those different axial zones. So here specifically, we're going to talk about the L4-5 disc level. So this means it's the L4 vertebrae above, L5 vertebrae below, and this is how the nomenclature for the disc is an L4-5 disc. And here you see different zones of herniation. So these are all extrusions in this picture. So this is the paracentral is kind of the old nomenclature. Now it's either left central or right central. And you could see that it gets the nerves that are traversing. So the nerve that's on its way out the door at the level below. The nerve at this level has already exited. So at the L4-5 level, if there's a left or right paracentral disc herniation or a subarticular disc herniation, which is just lateral to this, you tend to get the traversing nerve. If you're more in the foraminal zone, so now this disc is going into the foramen, you're getting the exiting nerve, and the nerves that are traversing tend to escape and they get skipped. And then the disc herniation, if it's extraforaminal outside the foramen, then you're also getting the exiting nerve. Kind of another quick distinction, if you think back to the initial slide where we did the dissection, the DRG, or the dorsal root ganglion, that's what tends to hurt the most. If the nerve is pushing on the DRG, those patients tend to have a lot of pain. They might end up needing surgery if you're not able to help them with an injection. Another thing to keep in mind when you think about electrodiagnostics and when you get those study results, someone who has a disc herniation that's either at the DRG or proximal to the DRG or preganglionic, they may have a normal EMG study for for a few weeks prior to it presenting on an EMG. So just because someone has a quote unquote negative EMG doesn't mean that they don't have radiculopathy or spinal nerve involvement. Facet joint or facet syndrome. So now we're talking about the a true synovial joints that are in the back. So they do have a meniscus. They have a tiny meniscoid, and they have synovial fluid in it as well, and it's surrounded by a capsule. Etiology of pain from this is usually, so whiplash injuries. When we talk about whiplash injuries, it's kind of a combination of both a capsular tear and insult, and sometimes you can have these synovial folds that kind of get impinged on themselves that can also cause pain. Prolonged postural strain can also increase load on the facet joint. This isn't something that happens acutely. This is more of a chronic or chronicity type issue. And then spondylosis, we kind of went over that term and what that means, but it can ultimately put more load on the posterior elements, which can cause facet arthropathy or facet syndrome. So most commonly, when we talk about OA of the spine or osteoarthritis of the spine, this is what we're talking about. We're talking about facet syndrome or facet-mediated pain. So as the disc or degenerative disc disease is what DDD stands for, as discs start to dehydrate, 70% or a significant amount of the compressive load gets transferred from the disc to the facets posteriorly. That excessive load causes osteophyte from Wolff's law. That might show up on your boards too. So increasing load on bone, the body puts down more calcium deposit, which essentially becomes an osteophyte. That can cause compression of the nerve, either in the foraminal zone. If that's more medial, then it can be in the spinal canal. And then there's an inflammatory component, which leads to pain. So this is kind of the natural history of this is kind of the kind of the trajectory of what happens with facet syndrome. Usually when you have facet syndrome, it's especially with osteoarthritis, it's not usually one level, it's multiple levels that are involved. And then 30% of patients with axial pain, axial low back pain, it's actually coming from the facet joint. So when you learn about facet syndrome or facet mediated pain, yes, it's axial, which means it's kind of localized to where the pain is. This is an older study, but it's been reproduced multiple times in different ways or different manners. And just understand that you can have a radicular type pain with lumbar facet mediated pain. So it tends to be localized, but it can go into the butt cheek and even down the back of the leg. Usually it doesn't go beyond the knee. It's pretty rare that you can get pain beyond the knee, but just because someone has a radicular type component doesn't mean that it's not facet mediated pain. Spondylolysis. So this one I'm going to spend a little bit of time on. So spondylolysis is a defect of the pars interarticularis, and there's a continuum here. So it's not just reaction to fracture. It actually goes through 4 different stages. So you go through a stress reaction. So this is usually an athlete who's loading that area, usually with an oblique extension. And that initially causes a reaction phase. If that continues without downtime, you can have a non-displaced acute fracture. This can progress, again, if not treated, which can cause a small gap or a mild displacement with or without fragmentation. And then terminal means that it's completely fractured and now it's well corticated. And then this can lead to non-union or something called pseudoarthrosis, where it's complete sclerosis and your prognosis for healing is pretty poor, or sorry, prognosis for the fracture healing is pretty poor. And you just have, 2 permanent fractures or 1 or 2 permanent fractures, depending on where the pathology is. Spondylolisthesis, this is kind of, again, kind of along the continuum here. So this is the farthest level of progression. So I think in medical school, it's kind of taught spondylolysis leads to listhesis. There's multiple stages before it gets to listhesis. So spondylolysis does not equal it's going to go to listhesis. So just another kind of take home point here. As far as imaging, this is kind of all over the place, and I've looked at a couple different studies looking at imaging, kind of the optimal imaging. There's really no consensus or consensus algorithm. And those of you who have dealt with patients with spondylolysis know that there's a lot of gray and without much black and white here. But just some things to think about when you're thinking about what image should I order for a patient that has potential spondylolysis. So the first question is it necessary to start with an X-ray, a lumbar X-ray, as an initial screening tool? And then again, this is kind of all over the place. It depends on the practice patterns of your clinic. So our clinic, I'm at a spine center where everyone kind of gets an X-ray walking through the door, but you might be at a more of a musculoskeletal clinic or an athlete clinic where that's not the case, and you have a little bit more control over that. But in general, X-ray has pretty low sensitivity, specifically in the early stages where it's the most critical. So if you kind of go back to the previous slide of progression, you want to catch it as soon as possible, as early as possible. And even if you have, a quote unquote positive sign on your X-ray, you're still going to get advanced imaging. So the thought of doing an X-ray, yes, a lot of clinics do it, but you may or may not want to do an X-ray initially, especially if you have a young athlete and you're thinking about exposing them to radiation. Another part that I didn't put on here, but I think is important to understand is getting obliques or kind of a Scotty dog view. That's fallen out of favor. So this used to be something that was commonly done where they would do an AP lateral and add oblique views to see if you can get a better view of the pars intra-articularis. And that's kind of fallen out of favor because one, it adds more radiation, and then kind of going back to these bullets, it's pretty low sensitivity. So even if you look at it, you might miss it in the early stages. As far as advanced imaging goes, MRI is probably a good reasonable place to start. So the accuracy is pretty high. It's very sensitive for stress reactions, which is the earliest stage of a spondylolysis. And then you can consider adding an adjunct CT if you want a better look at the cortical bone. So MRI is very good at looking at bone marrow. And then the CT scan is a little bit better looking at cortical bone. So if you have a question of, is this stress reaction now gone all the way to a fracture, and you want to see if this is well corticated or not, a CT is kind of a gold standard for that. A lot of centers who see a lot of young athletes have protocols for this to kind of minimize both time in the MRI machine. So if you have a young athlete and you're trying to keep them in an MRI machine, a lot of them don't like it and they don't tolerate it well. So there's some protocols to look just at the L4 and L5 level, which is kind of the most common location for this. Same thing with CT protocols. You can do thin cuts just through the pars that you're trying to look at. So you're minimizing radiation while getting all the information that you need. And then as far as the SPECT CT scan goes, this again was something that was kind of popular earlier. It's a little bit falling out of favor just because of the high dose of radiation that you're giving to a young adult. But it can be considered as an alternative to an MRI if an MRI is contraindicated for whatever reasons, if the patient can't tolerate it, or it's non-diagnostic because of poor patient compliance, or the patient moved a lot in the MRI and you're not getting good results with it. SPECT can be considered as an option. So as far as management, again, this is a lot of gray, which is why there's a lot of bullets, but I'm going to talk you through some of this stuff, and then you can have the slide to look back to if you want a place to start. So things to consider. First, I would consider, is this an incomplete or a complete issue? If it's incomplete, that actually has a good potential to heal. And then those that are unilateral also have a better potential to heal compared to a bilateral spondylolysis. And then trying to really put the grade on where are we in the spectrum? Are you in the early stress reaction phase? If that's the case, this is a good conversation to have with both your athlete and the parents and possibly the coaches. Like, we need to arrest this patient now and then prevent them from going down this pathway. If you're already into a true fracture phase, then it's a different conversation altogether. If you have a complete spondylolysis, the potential to heal at that point is pretty poor. And now you're trying to figure out, is this more of a subacute issue where you still have some potential options, or is this more chronic of an issue where this person, has what they have and maybe they can still play through it, but they already have a fracture. And this might, someone with a complete spondylolisthesis, they may end up going to completion with a spondylolisthesis. So as far as options go, so I'm not gonna, sorry, I'm gonna kind of start at the top here and then kind of work my way down. So bracing, there's a lot of studies looking at bracing. They're pretty heterogeneous as far as like the type of brace that was used, how long a patient was braced for, any adjunctive therapies that were used. So they're pretty heterogeneous. They're pretty hard to compare to each other, and they're kind of conflicting. Some recommend it, some don't recommend it. Some big picture takeaways, if you do consider a brace for your athlete, they have to be in it for a long period of time. So 22 to 23 hours a day, which is essentially all day. And then the brace that you use has to adequately restrict the L5-S1 level. That's usually the level that's most commonly involved. So a TLSO or thoracolumbar spinal orthosis, or just an LSO by itself, won't do that. It's not going to restrict it. So you have to add a extension to the thigh. So think about your athletes. How many of these athletes are going to tolerate this? So something to think about when you're thinking about bracing as an option. Physical therapy is still kind of the mainstay of treatment after resting. So really the focus should be on core strengthening, a flexion-based lumbopelvic stability program, and then really working on hamstring flexibility if they don't have it. Bone stimulator, again, it's there are not a lot of studies on bone stimulators. So kind of the big picture takeaway with bone stim, one is can they get access to it? And two, really studies have shown that there's higher rates of radiological healing compared to those that didn't get a bone stimulator. But as far as return to sport, which most of your athletes, that's what they're really looking for, there's really no difference with someone who uses a bone stimulator versus not a bone stimulator. So again, a conversation to have, and then is this resource even available for the patient? Interventions are pretty variable, and it kind of depends on the stage that you're in. This is worth a conversation with your interventional spine doc if you're going this route. There are different ways to address pain with someone who has PARS. One big caveat that I would put out there, if you're in the early phase and you have an inflammatory response, it would probably not the best idea to put a steroid in there. It's probably going to delay the healing and increase the chance of a non-union. So just things to think about or consider. There are PARS injections. There's some studies looking at putting medication directly into the PARS, but if you think about the PARS itself, it's a small area, and medication or fluid's not going to stay there. It's going to stay maybe for a little bit. It might be helpful diagnostically if you're trying to figure out, is this a cause of axial pain, but it may not be therapeutic. Facet joint injection is also something that's been considered. So this cartoon kind of shows the relationship of the facet joint at the level above in relationship to the pars interarticularis. And there is a channel that communicates with someone who has a pars defect or this pincer-like deformity. There's some morphologic variants. So people who have spina bifida occulta, for example, have this more of a pincer type deformity where the superior part of the facet joint and the inferior part of the facet joint causes this pincer-like activity on the pars, which increases your risk of having stress injuries to that area. So you could have a facet joint injection, which can communicate with the pars. So this would be an intra-articular facet joint injection. There's some controversy of medial branch medial branches actually innervate the joint. Does it also innervate the pars given this relationship? That's still kind of being studied and looked at. And then another kind of controversial area is if you do a medial branch block, do you progress all the way to doing a radiofrequency ablation? So you're ablating the nerves that go to the facet joint, but are you also ablating the multifidus muscle? And how is that going to play into an athlete's performance if rotation and extension is part of their sport? So lots of question marks here, but just things to ponder when you're seeing your athletes. And then finally, as far as surgical treatments, I'm not get into that just because it's not my area, but a good prognostic talk that you can have with a lot of these athletes are majority of these. So some of these studies say 80%, some say 90%, but it's majority of these get better with non-operative treatment. So that is a nice data point to give your athletes as well. And then with the remaining time here, I'm going to go through some other differentials. I'm not going to spend sorry, I didn't progress here. So I'm going to go through some of these things that are commonly diagnosed, but just getting some nuances as to understanding of what might actually be happening. So posterior pelvic pain, there's multiple articles, probably volumes of articles at this point looking at posterior pelvic pain. Is it truly SI joint pathology or not? So this has kind of gone through some pendulum swings as well, as far as the diagnosis of SI joint pathology or SI joint mediated pathology. So initially, before 1930s, 1940s, was a common diagnosis just because there's a joint in that buttocks region. Possibly it's moving and maybe it's causing buttocks pain. And then the kind of landmark study from Mixter and Barr in 1934 described disc herniations as a source of lumbar pain radiating to the buttocks region as a source of pain. So SI joint kind of fell out of favor as a potential diagnosis, or kind of a higher up in the differential for diagnoses. And now, more recently, as we have more interventions to stick needles into the joint, fuse the joint, burn things around that joint, it's kind of, come back into vogue. So just take a step back and think about what is the primary source of pain when we're talking about SI joint pathology. So it's really the dysfunction of the joint or the dysfunctionality is increased motion of that joint. If you do there's an epidemiology study kind of looking at people in a spine clinic, looking at true source of pain, if it's the joint or not, and it's about 10 to 26%. So think about the patients that you're seeing. How many of them are you diagnosing with SI joint pathology, and does it fall into the ballpark of, about a quarter or less of your patients having it with back pain into buttocks pain? And then as far as the actual hypermobility component, so these are some of the things that I think about that can cause hypermobility in that joint or increased mobility in that joint. So true leg length discrepancy. So this is someone who has a lower extremity amputation and they have a true leg length. One is significantly longer than the other. That forces increased force on one joint compared to the other. Those with inherited hypermobility syndromes. So things like Ehlers-Danlos, Marfan syndrome, other connective tissue disorders that don't have a named diagnosis. Pregnancy-related ligamentous hyperlaxity. So this could be peripartum, either around the time of pregnancy, so either just before, just after, or during. And then significant scoliosis can cause this as well, because you have forces that are more, or imbalanced forces more on one side versus the other. And then something that I see a decent amount in the spine center is patients who have fusion all the way into that sacrum. You've lost motion in the L4-5 segment and the 5-1 segment. That motion has to go somewhere. That tends to go through the SI joint, and they can get pathology there. And then think about the treatments for this. So it's a hypermobility syndrome. So it's an increased motion of that joint. So the treatment should be decreasing or stabilizing musculature in that area. So not trying to stretch that area more. It's going to aggravate symptoms. Same thing with piriformis syndrome. This is another diagnosis that has kind of stuck around. Again, great diagnosis or great theory for like the cause of pain prior to 1940s, when MRI wasn't as good. Now with imaging studies, we know that it's most of the time it's not the sciatic nerve that's compressed. The piriformis muscle looks normal in a lot of patients with buttocks pain. It tends to be from a spinal nerve, or there's a functional imbalance for some reason. So a bigger, broader term that helps explain some of this stuff is deep gluteal syndrome. So it's not just the piriformis muscle that's there. You also have the gemellar muscles that are in there. The other things to consider are obturator muscles. So the obturator muscles start in the buttocks, deep gluteal region, but they also dive into the pelvic floor. So if you have patients with pelvic floor etiologies or pathologies of pain too, just keep your differential broad and don't narrow in on only onto one specific muscle. The other thing, as you guys are going through your fellowship, I think it's pretty easy to understand that muscles don't act in isolation. So just labeling the piriformis as the culprit, I think is, we need to broaden that perspective a little bit more. So deep gluteal syndrome, there's some really good articles that dive into this topic of deep gluteal syndrome. But think about what else is in the area, what else could be causing symptoms. And there's multiple muscles in that area, multiple co-contractions that are happening. And there are some anatomic variants that could be causing this as well. And I'm happy to talk about this in the Q&A if we have a little bit more time. And then kind of other take-home points, think about how you talk to patients. So the words that we use matter, and what we say as physicians to your patients really stick to it, especially once they get a good relationship with you. And they kind of take this, to heart. So these words like degenerative, bone on bone, disc rupture, wear and tear. Think about what the patient thinks when you're saying something like this. So we're a biological entity, we're not purely mechanical. So if something is wearing and tearing like a bicycle, the thought is, I'm not going to ride this bicycle any longer, or I'm going to replace this with another part. So maybe I need a replacement of some kind. That's not the case. And we know that from your fellowship and from your, seeing patients, we want our patients to move. We want our patients to be active and moving their joints, moving their muscles, getting stronger, working on that neuromuscular control. Some of these words have negative connotations associated with it, which might push that patient another way. So there's some good studies. There's some articles published recently through the BJSM that talks about some of this stuff, where talking about the way you talk can push a patient more towards interventional surgical procedures rather than more of a physical therapy activity based treatment pathology. So weigh your words. And then kind of big picture general rehab principles here. The good news is most of these back etiologies or episodes get better. Think about what's causing it. So what is the risk factor? How does this patient get there? How do they get to your office? And how do I prevent this from becoming a chronic issue? Other things to think about are therapy or what you do for this patient. So in general, splitting therapy into passive and active therapies. Passive therapies like manual therapy, heating, massaging, icing, stretching. Those things are helpful, but they tend to be short-term and short-lived. Things that are more active, where you're working on strengthening neuromuscular control, mobilization, active mobilization of tissues, that gives you a longer lasting relief, and then it kind of sets that patient up from preventing future injuries. And then kind of moving on just here for the sake of time, we can go back to some of the stuff if people have questions. So when we're talking about putting someone into therapy, think about mechanical diagnosis and treatment has the highest level of evidence for therapy. So this is essentially putting this patient, figuring out what their directional preference is. So they have more of a flexion. If they have pain with flexion, put them into an extension program. If they have pain with extension, put them into a flexion program. And really the thought or kind of the idea behind this is force progression. So you're starting with static patient-generated forces, and then you're moving to dynamic patient-generated forces. And then you can get the physical therapist involved to generate forces as well. So here's kind of an example. This is actually my co-fellow who demonstrates kind of a patient-directed static generated force to a patient-generated dynamic force. And then we don't have a physical therapist here, but it'd be a therapist kind of laying hands on. So he's trying to touch his toes. He's doing what he can here, and then having a therapist to kind of help him along that pathway. So mechanical diagnosis and treatment is the highest level of evidence for patients with spine pathology. So think about direction preference and then put them into one of these programs. As far as procedures, I'm not going to dive into details of all of these procedures, but big picture, these are some things to think about. So splitting them into, do they have radicular type pain or is it more axial pain? If it's radicular, that is what we think about epidural injections for. And there's different flavors of epidural injections. So depending on where you're putting that needle and what you're trying to target, you could do either interlaminar, transforaminal, or caudal type injections. And then for joint pain, medial branch blocks have the highest levels of evidence for it. So essentially, each facet joint has a nerve from above and a nerve from below that innervate it. So blocking that joint, so giving a nociceptive pain block or anesthetic block, seeing what kind of relief they get with it. If they get good relief, then you can proceed to an ablation. Intra-articular injections can be considered kind of on a case-by-case basis, but if you think about the facet joint and how much volume it holds, it's pretty small. It's in the order of 0.5 cc's or less. So for reference, a tablespoon is about 5 cc's. So 0.5 is pretty minuscule. So think about it, someone who has an arthritic joint, how much volume is that joint actually going to hold? And then the ablation itself, some controversies as to, is ablation or burning nerves kind of the best answer or solution? And, there's a gray area there. Happy to talk about that later too. SI joint mediated pain, you can do an intra-articular injection, so putting medication to the joint. Same thing here, that joint doesn't hold a lot of fluids, more than a facet joint, but not a ton. So if you're putting medication to that joint, there is some thought that the posterior ligamentous structures can also play into some of the pain. Lateral branch neurotomy. So there are branches that innervate the posterior aspect of that joint, which we can either ablate or anesthetize. The anterior portion is that's a little bit more harder to access. And then PARS, we kind of went into some of the nuances there. Spine surgery, just kind of, again, big picture, broad strokes, when you're thinking about a patient who has tried physical therapy, who's tried interventional options, and they're still having issues or pain. These are some of the indications for different types of spine surgeries. So if you have a degenerative degeneration of a disc or dehydration of a disc, which is causing facet arthropathy, these are some things to think about. Herniated disc, this is kind of in the acute phase. So these are patients who have with radicular symptoms with progressive weakness that's not getting better. So we could talk about this in the Q&A session, but really thinking about radicular versus radiculitis versus radiculopathy. Radicular is what the patient tells you. Radiculopathy is pathos of that nerve. So not only do you have radiation or radicular pain down a spinal nerve dermatome, but you also have reflex and myotomal involvement. That's true radiculopathy. If they have just pain down a dermatome, that's actually radiculitis. So that distinction clinically is important because surgery might be on the horizon if they have radiculopathy that's not getting better. Spondylolisthesis, there's some surgical options for that. And then same thing with scoliosis. This is in your early development. So, and you can split these into like either idiopathic or neuromuscular, which is beyond the scope of this talk. And then kind of, again, very big broad strokes types of surgeries that are considered. Laminectomy, that's where you're taking up the posterior element. That can help with someone who has more of a central canal stenosis. You're opening up that space. Discectomy for disc-mediated pathology. A fusion, this is usually someone with an instability, and there's multiple causes for instability. Artificial disc replacements. So cervical spine, there's a ton of evidence for artificial disc replacement, and the lumbar spine literature is catching up to that pretty quickly. So this might be the next wave, as more of a motion preservation type surgery for these patients. So big take home points here. Think back to kind of, and when you think about anatomy and pathology, think of the spine as a 3-joint complex and the relationships and how that plays into pathology. Think about directional preference. So when you're putting a patient, you're thinking about a patient and thinking about differential diagnosis. Is it worse with flexion? Is it worse with extension? Is it worse with both? Maybe they have a yellow flag component to their pain. What is the source of the radicular pain? So is it a spinal nerve, or is it something else that's causing this? Is it peripheral nerve entrapment? Is this a joint, like a facet joint, causing pain down the leg? Is it a hip? Hip can also give you radicular type pain down the leg as well. So think outside the box if it's not something clear cut as a spinal nerve. When you're writing your PT scripts, at minimum or baseline, make sure you're incorporating mechanical diagnosis and treatment-based treatments, because this has the highest level of evidence for patients with spine pathology. And then physical therapy, make sure that when they're doing it, and you're seeing them, ask them, yes, did they do physical therapy or not? But the next question is, what did they do in therapy? If the therapy doesn't make sense to what they do in life or sport, they're probably not going to do it. So giving them some goal-oriented therapy can be helpful for that. And then kind of last thing to think about as physicians and kind of big epidemiology burden is make sure we're not missing those yellow flags and sending these patients down a chronicity type pathway. All right, so that's it for the talk. I do have some CAQ questions. So Andy, if you want to do the polling, I'm gonna read out the questions, and then thanks. I'll read out these questions and then you guys can do your poll. So let me see if I can move. All right, so first question. So you have a 30-year-old Olympic weightlifter that notes an acute onset of right-sided lower back pain with radiation down her leg into her foot. She denies any red flag symptoms on history. A neurologic exam is unremarkable other than the fact that she has a positive straight leg raise and a positive slump test, both of which reproduce concordant radicular symptoms. So concordant means the same pain that she's coming in with. She receives a lumbar MRI, which shows a right subarticular / paramedian disc herniation at the level of L4-5. Which nerve is most likely involved? Awesome. All right. So it looks like majority are saying C, and then there's a handful of B and nothing for A or D. Good. All right. So I'm going to put back the slide from before. So this is the L4. If you think of this as the L4-5 level, we're talking about this right here. So you're going to get the traversing nerve. So at the L4-5, the nerve that's traversing is L5. So here's the L5 nerve as it's coming down before it exits. The L4 nerve at this point has already exited. So the answer to this question would be L5. All right, question number 2. 40-year-old, sorry, let me move this for a second. So a 40-year-old recreational pickleball player has been avidly practicing his right-handed serve for an upcoming charity tournament. He notes that at the end of these sessions, he has a dull ache in his right lower back, radiating into his right butt cheek. He promptly Googles his symptoms and diagnoses himself with piriformis syndrome. What is the incidence or the true incidence of piriformis syndrome in a patient with buttocks pain with intermittent radicular symptoms? Good. Looks like majority of you got this right. So this is one of the slides. If you kind of go back to his PowerPoint, it's no worries. So yeah, so 6 to 8% is pretty low. So less than 10% of patients with buttocks pain truly have piriformis syndrome. And then last question here. A 14-year-old competitive gymnast has been experiencing left-sided axial pain for the past 2 months, which has now become daily in frequency. She does not endorse any radicular pain and has a benign neurologic exam. She receives a lumbar MRI, which shows the salient feature of an increased T2 signal of the left pars intra-articularis without a fracture line. Based on the current evidence, which of these statements is the most correct regarding her prognosis for return to sport? So this wasn't explicitly in the slides, but this is kind of a interpretation of, or kind of extrapolation of some of the things that we talked about. Good. So we have a mixed bag of answers, and there's no correct answer here, but so number 1, good. I'm glad no one picked A. So surgery is pretty low as far as patients requiring it. So the answer that I would, so what I would probably recommend is completely shutting this patient down from gymnastics for at least 4 months. So if it looks based on this MRI, they're in the earliest stage of a stress injury with the PAR. So the best prognosis is to kind of shut them down from sport completely and allow them to recover and heal, and then get them into a core strengthening flexion based program with hamstring stretching. So that'll be kind of the first thing to recommend. Some of these other options, so bone stimulator. So going back to that slide, there's evidence for it to show radiologic healing, but this may or may not mean that she can go back to this high level of competition that she was at. Same thing with the PARS block. It can be helpful as a diagnostic for saying that this is the cause or the mediator of pain, but it doesn't necessarily improve return to sport, improve chances of healing. All right, that's all I have. Happy to answer any questions. I do have a decent amount of references. I don't want to put all of it on here in like, size 2 font, but if you guys have questions or want more sources, I'm happy to send that your way as well. And I'm happy to answer any questions anyone might have.
Thank you, Dr. Raghunandan. This was a great lecture. I know spine pathology can be a very dense topic to cover within an hour, and each pathology can be its own talk, certainly. So thank you for a great overview of the spine pathology. I do have one question. I know we are at 9:37 right now, but let's answer this question before we finish up.
Sure.
So the question is, let me see. So he wants to know, would you mind sharing the way you explain facet arthritis to a patient to avoid questionable language? How would you kind of describe the facet arthrosis to the patient in your clinic?
Sure. Yeah. So, so one is it depends on if this is the patient's mediator of pain or not. So, if someone, so kind of I split it into, does this person have pain or not? What's the level of pain? And is this interfering with their daily life or quality of life? So my first go-to usually is not an injection. It's what are we doing? Like, how did you get here? And then how can we fix that? As far as language goes, it's to normalize it as much as possible. So essentially I tell them kind of what I said. So I say you live on life, you're living on Earth with gravity. You're gonna have dehydration on the disc. Over time, those discs are gonna lose height, and then you're gonna put load on the joints. which is going to cause pain in that joint. It's like getting gray hair and wrinkles in your spine. Some patients have pain with it. Some patients don't have pain with it. You have pain with it. Let's figure out some options as to how to mitigate that pain. So that's usually kind of how I start that conversation. And then from there, I let the patient kind of take over as to which direction they want to go with it. Some patients want to be really aggressive where they've tried different types of therapy already, and then we might go an interventional route with them. If someone is kind of brand new to my practice and they haven't tried anything, then we start with like figuring out what they want to do in life, and then writing a physical therapy script based around that.
Great, thank you so much. So I don't see any other questions. I'm sure people may have, or like later on. So would you mind like sharing your email address or something in the chat so that people can
Sure.
answer,
Yeah,
like ask some questions later on if they have any?
yeah, definitely. I put that in right now.
Perfect. But otherwise, thank you everyone for joining, and thank you again, Dr. Raghunandan, for a great lecture. This was one of the best lumbar spine pathology lecture for sure. So thank you again.
Thank you. Yeah, my pleasure. Thanks again for everyone.